Mr. Chairman, ladies and gentlemen, precision patient care in vascular treatment, the power of artificial intelligence. Innovators and early adapters. Clinical community is diverse. One end of spectrum are innovators and early adapters who are enthusiastic about adopting new ideas, or late majority and laggards who will never accept any solution no matter how many others use it or how promising it will be. The hierarchy of artificial systems, and basically artificial intelligence divided into diagnosis, which give you a very accurate and rapid diagnosis, surveillance, which reduce the heavy work, individual risk stratification, when to intervene, and prediction for early intervention, which is becoming one of the major ideas of building a very good machine learning system, and treatment analysis, how to intervene, and development of precision therapies. And this applies to everything from patient cohort to patient-centric to diagnosis and scanners. When to intervene, we are using 4D MRA arterial compliance to see exactly when it's early to interfere with small aneurysm, early dissections, and predict what's going to happen. However, this has to be materialized into algorithmic way for precision medicine of such patients. Machine learning will require human input, algorithm created from data, then data analytics, which will minimize human interaction because it analyzes through algorithm, build on algorithm, you build it yourself, and then the machine deep learning, where biosynthetic neuronal network, you have nothing to do with it, it will do in its own, and this is the craziness of the situation. You cannot control machine deep learning, and it will handle unlabeled, unstructured data. Currently, we have moved from narrow artificial intelligence, where the machine IQ is 0, to general artificial intelligence, where recruiting patterns, machine matching human cognitive capacity. However, super artificial intelligence, we haven't reached that yet, but we're getting there. It allows machine surpassing its cognitive capacity and self-learning. The fifth cardiovascular revolution. It's essential to understand that with time, artificial intelligence, intelligence swarming, and knowledge center services will grow exceptionally in cardiovascular medicine. The significant economic burden associated with its initial implementation will decrease not only over time, but also the return on investment will be worth the initial capital buy-in. We'll take an example of diagnostic errors with lethal outcome. Aortic dissection is a time-critical medical emergency with an 80% survival rate when diagnosed and treated on time. However, more than 167,000 people lose their life to aortic disease every year. 50% with aortic dissection are misdiagnosed. 33% actively treated for the wrong condition, and 11% cardiovascular maternal deaths due to aortic dissection. See how far we in diagnostic.
Six Sigma for a very complex. We just launched the first VFR with bifurcated graphs. And as you can see that we go with Six Sigma, we don't go from 1 to 2 except when we have done first. We don't go from 11 to 12 except we have done 11 first. Regardless, you don't change. When you have this, the amount of mistakes goes to less than 0.01. Yeah.
Healthcare system have a lot to learn from other industries. Six Sigma, like what used in the aviation industry, that employ best practices to build robust AI algorithm solution to enhance efficiency and provide seamless workflow. You have to avoid errors, and the biggest errors you'll ever have is when you are under extreme undue stress during big surgeries. EVAR in 2022, inconsistent information management, whatever you tell me is inconsistent. You have a bad reg, bad SHO, bad assistant, and bad implantation, wrong graft in the room. There's a lot of problem that you can live off your control. And lost information, unavailable information, and incomplete information give you a lot of errors. Artificial intelligence improve aortic surveillance. AI assistant reduced radiological reporting time for aneurysm follow-up by 63%, aortic dissection, and aortic prediction of re-intervention. All EVAR graphs failed due to obsolete passé technology, and you know about that. All of you have this major problem with these failing graphs, and you don't know what's going and what happened, and we have to start preventing this. And the only way to do that is to look at the pattern of presentations. FIVAR carries greater re-intervention risk than open surgical repair, with implication for cost effectiveness. Patient who underwent a secondary intervention for type 2 endoleak done worse, and it reinforced the need for conservative treatment of type 2 endoleak. Patient in high score group had more implanted-related complications. So if you have a complex CFR, you better do it open. Endovascular aneurysm sealing with polymer-filled endobags had failed because of lack of proper regulation system in Europe and in the United States. The CE marking and the FDA have failed us. Again, let's apply just the middle of the road. General artificial intelligence will be looking for recurring patterns, machine matching human cognitive capacity. So the first thing that we like to see is how to diagnose the problem. And this is, we have mastered the prone contrast enhanced computed tomography angiography PASHA, where we get the patient, put him on his face in order to allow identification of the type of endoleak, so that you don't say that it's a type 4 or type 5 or concealed endoleak. There is definitely a problem. And if you allow this through PASHA technique, you'll understand what's going on, because that type 3 chronic fabric fatigue failure is the major problem. All the graft that we have implanted 20 and 22 years ago is coming back to us and coming with the chronic fabric fatigue failure. It's a failure of the graft itself. And we have to start looking at how to treat this problem. So we have created Arafat or Ivar Gore salvage fabric technique. We realign the graft so that we don't explant. In our early series, we used to explant. Now we do Arafat. Very simple. Everybody could do it. And it's the only way to save the patient without converting to open repair. PASHA and Arafat are a fully functional protocol to overcome apparent challenges in accurate diagnosis and subsequent concealed endoleak management high-risk patients. So this patient came in with 4-phase CT scan, expanding sac. We put him on the face. The aortic sac have lit like a Christmas tree, as you can see in the middle of the CTA, and then we have applied PASHA Arafat to treat it. The other problem that aortic sac hygroma is a rapidly increasing AAA sac more than 75 millimeter and associated with severe abdominal pain and low back pain, was documented Hounsfield less than 25. In a state of an implanting polyester-based graft is an aortic hygroma, and do not mess around. We have created an evolving algorithm as experience grows, a sustained gradual increase in an aortic sac that exceeds more than 7.5 centimeter as indication for prophylactic intervention, and it's well published, and please follow that protocol if you can. Moreover, when you do that, you're required to do an operating endoaneurysmography with EVAR preservation. We have a low threshold of opening the aortic sac. We opt for the evacuation of hygroma and double breasting because of fear of aortic sac rupture, leading to high morbidity and mortality. Again, we start applying artificial intelligence, only the general AI, to look at recruiting patterns for the problems and to see exactly how we could deal with the graft explantation and graft preservation in a very strong algorithmic way. What we found that 36 millimeter proximal diameter aortic cuff with more than 4 modular components with limb size above 23 millimeter had a higher chance of graft fabric failure, hygromas, and late complications. Reduction in profile cholesterol graft to reduce stent graft profile had caused long-term sequelae of chronic fabric fatigue, hygroma, augmented by use of thrombolysis, DOACs, and antiplatelets. Polyester grafts augment post-implantation syndrome with high interleukin 8 level and act as a neutrophil chemo-attracting that exert pro-tumoral function and play a role in tumor progression and metastasis. Then you do a very good TVAR and EVAR for whatever aortic transection or for a thoracic aneurysm, and then the patient starts having severe chest pain and systolic hypertension. You do a coronary angiogram, and all these patients had coronary angiograms, and all the arteries are normal. So what's going on? We started again looking at it. The evidence of adverse hemodynamic alteration post-TVAR, EVAR. Therefore, the best solution in the short term is to reduce the stented length of the aorta, while in the longer term, encourage continuous improvement in stent graft material and design. Again, we'll start looking at it in a different way by recruiting patterns and machine matching human cognitive. And what we find that endovascular graft induced cardiac failure. Stents graft biomechanical properties are several orders of magnitude stiffer than native aorta. Material that enhance durability, but it stiffens aorta. Aortic compliance critical to reduce impedance and cardiac workload and aortic oscillation. And the loss of wing cell effect and alteration in pulse wave propagation result in adaptive left ventricular hypertrophy, loss of diastolic systemic augmentation and reduced myocardial perfusion, and induced ischemia despite the absence of coronary artery disease. And this is related to combines thoracic endovascular aortic repair and endovascular aneurysm repair, and the long-term consequence of altered cardiovascular hemodynamic or morbidity and mortality. And we got it into European Heart Journal. And what we find that TEVAR induces acute aortic stiffness within 24 hours of inserting it. Medical device manufacturer must consider impact of graft stiffness mismatch, particularly when emerging rural TAVI and arch BVAR is coming around. Aorta is a functional organ which we should respect, preserve, and not eliminate. Regional aortic bioarchitecture varies considerably with implication for tissue function, and current devices lack compliance and induce cardiac dysfunction. Next generation devices must restore aortic compliance to reduce cardiac deaths. Then we start talking about the stage hybrid single lumen reconstruction to decrease the stenting of the aorta to decrease this problem. And what we find that Tiger shortened the stented segment of the aorta, avoid critical shattering and dislodgement of visceral branches, and reduce the risk of negative cardiovascular consequences. There was no need for thoracotomy, partial cardiopulmonary bypass, or spinal drainage. Vascular surgeon must master the dying art of open complex aortic surgery. Tiger offered opportunity to improve long-term result of TEVAR for aortic dissection, definitely. Now, this is the amputation saga for critical ischemia over the past 27 years. And you can see the only difference is the pixelation of the camera. We're still doing amputation, and we're failing miserably in this to prevent this from happening. So there was two bigger Cochrane review and meta-analysis on stem cell. And after a couple of billion of dollars, they found that placebo effect is superior to stem cell therapy. Then we start looking in it. What's the reason of this problem? What's the recurring patterns and the machine matching problems? And why there's progress from claudican to critical ischemia in less than 10%? Why mitochondria fail in CLI? Why there's sarcopenia and smoker diabetes mellitus and effect on critical ischemia? And all pointed to one thing: we have to recruit the capillary bed. Capillary bed recruitment promotes healing and improve limb salvage when revascularization options are unavailable or exhausted, and when established treatment alternatives are lacking. We're using this technology that we adapted from NASA in 2000, and basically it improved the circulation of the feet by gravity. It recruited the capillary bed and allowed delayed limb salvage in zero option patients. However, there's still some patients require something else, and that's why we started to do DVAR post-capillary bed recruitment. The patient comes in, have the arthrosis, and do a bypass from the distal aorta, as you could see in here, up to the anterior tibial and do an AV fistula. And we started doing this in and out and becoming a routine practice for patients coming in with acute thrombosis for COVID, because it's the only way to save the leg for patients who were previously all right. Trying to do a thrombectomy is a waste of time. The continuous failure of intravenous TPA is a major concern for all of us, because it doesn't work when you have this cheesy material in the common carotid, and it's only help less than 4%. Believe it or not, the intravenous TPA only help less than 4%. Evidence since systemic review and Cochrane review on carotid disease. And what we find that if we start looking at recurring pattern, patient comes to you late and people throw the towel. No, there's still some sort of a way. We get the patient in and freeze them, do a normal carotid, but we freeze them. We drop the temperature to 32 degrees, give phenobarbital to arrest the brain so that the isoelectric brain waves, only activity picked up in the forehead is the ECG. We arrest the brain as if you're giving adenosine. We give phenobarbital plus freezing the patient. And we started doing these cases, and now we have surpassed 100 cases doing it with this triple neuroprotection. And all this patient comes in totally, utterly ranking score very bad. They recover within 24 hours after we keep them in the ICU. Now, patient coming with acute carotid thrombosis post-COVID, do not do anything. Open the patient, do a bypass. The artery is diseased. There's vasculitis in it. You will never be able to do a TPA or anything for this. Open, do a bypass is the only way to save this patient, if there's any way. Despite the absence of control study to compare surgery or endovascular therapy in patients who failed antithrombotic therapy, carotid surgery in young patients can be justified as a personalized precision approach given high morbidity and mortality in young age. And when we do the patient, we get them ventilated to the intensive care unit. As you can see, the patient have the tube out of her mouth and she's texting her boyfriend, and all the patient keep them until they warm up and the phenobarbital totally goes off the body and they expiate themselves, and they do very well and they start mobilizing. The fifth cardiovascular revolution, AI will impact radiology, pathology, and general medicine, first leading to image and clinical pathway to be solely managed by machines. We can foresee that AI and big data analysis technology will extensively influence our cardiovascular clinical practice within 5 years and will augment patient care efforts. AI and big data analysis will improve scarce healthcare resources with personalized precision patient management plans. It will inform and impact policies and guidelines. It will expertise clinical trials with no more human guinea pig scenario. Again, artificial intelligence, and we are only applying the general AI. We have to create the commander. Current medical education is antiquated. AI and big data will pioneer a new division in medicine. This professional hyper physician, part computer engineer, and data scientist will increasingly embark on new role and shift from oracle to counsel to the commander, physician, computer engineer, and data scientist. Over time, human clinician will gear towards job plans and tasks that allow for uniquely human skills like integration, empathy, and persuasion. Healthcare providers who will not join the fifth cardiovascular revolution will ultimately lose their jobs over time. Creation of AI-empowered healthcare specialists is crucial for a brighter, sustained green future. Understanding algorithmic creation as a medical practitioner will rely heavily on contemporary technology, which might not always perform as expected. Algorithm training is mandatory to abolish and lessen the risk of bias. Thank you so much for the opportunity to present on precision patient care and vascular treatment. Don't tell me that it did not record.